All right. Well, I guess we're going to start. A lot of people are going to be missing out on what I'm sure is going to be a great talk. I have the great honor to introduce Dr. Rob Avery, who's a member of the Division of Ophthalmology at Children's Hospital of Philadelphia. Dr. Avery is also an associate professor of ophthalmology and neurology at the University of Pennsylvania. For those of you who don't know Dr. Avery, his primary research is investigates advanced ocular and brain imaging methods for monitoring and treating children with brain tumors affecting their vision. He's the principal investigator of 2 grants from the National Cancer Institute, 1 grant from the National Eye Institute, and 1 grant from the Department of Defense that investigates visual outcomes in low-grade gliomas. In particular, he's also part of the Gilbert Family Foundation's Visual Restoration Initiative, a multidisciplinary team engaged to develop first-in-kind therapies to restore sight to children with NF1. So it's my great pleasure to introduce Dr. Avery, a friend and a father of 2 sets of male boy twins 1 year apart. So take pity on him, okay?
Thank you, Bob, for that very kind introduction. I'm very glad to be here. This is a topic, obviously, I love to talk about, and I'm going to make this a little bit higher and dedicated my career to. And I've always been very, very thankful for being part of the NF community. I've often said that the NF community chose me rather than me choosing to be involved with the NF community. So I feel very lucky to be here. Let's see, this working. Yeah. There we go. As Dr. Lisch said, these are the folks that support our research. A special shout out to CTF that does a lot of great things for the eye community. In some disclosures, I consult for some pharmaceutical companies, none of which have anything to do with NF. And AstraZeneca supports some trials, clinical trials that I work on, but not directly to me. And I've spoken at some symposiums for them as well. But today is, talking about eye manifestations of NF is a broad topic. So I really kind of want to do my best to go over the who, what, when, where, and why of each of these manifestations, and hopefully have you leave here with a little bit greater knowledge. So a general overview, again, who is at risk in the NF world to have NF eye issues, what eye problems are related to NF, because not all of them are, where along the visual system are these problems located, how do we assess kids with NF with eye issues, why are we even doing this eye exam, and when is the best time to treat these eye problems, because timing is kind of everything in a lot of what we do. Now, even for gifted pediatricians like Dr. Listernick, us ophthalmologists speak a very weird language that is atypical even for the medical community. We have lots of weird abbreviations and things like that. And so my goal today is to give you the skills to understand some of those symptoms people talk about, or your ophthalmologist may talk about, just so you can understand your child's care a little bit better, and what we're getting at and why we're asking you about those particular signs and symptoms. So what is vision? We all have it's something we do every day and kind of take for granted, but there's really 2 types of vision out there. There's visual acuity, which is the clarity of your vision, what you do when you look at a piece of paper or you're reading something, really that finite level of acuity is your clarity. Whereas your visual field is your extent of your vision. So sometimes people call it your peripheral. It's really all of your vision, but we colloquially talk about it as our peripherals, but it's really the extent or how broad our vision is. So let's look at this. This is a standard acuity card that doctors pull out of their shirt pocket. And as you can see, as the letters get smaller and smaller, you really have to have better and better vision to get the clarity of, is this a D or an E or an F or a P? But visual acuity is not just something that you statically have. In children, It's a developmental milestone, just like any other developmental milestone. When we're born, you don't just get up and walk away from the hospital and meet your mom at home. It takes you a year and a half to learn how to walk. And then you're not too good on your feet and a little uneasy. And then you learn to walk a little bit faster and then run and then skip. And it takes years to be able to do that. Vision is no different than that. Vision takes time to develop. And so when you are born down here, or you're around 6 months of age, I have some years cut off down here, is your vision's pretty bad as a baby, 2100. And as you get a little bit older, around 2 and 3 years of age, your vision's still pretty bad, 2050. The DMV wouldn't let you drive a car at this with this visual acuity because it's not clear, but your vision is developing and your brain and your eyes are becoming more and more coordinated. And as you get older to 3 and 4, you come around the 2030 range, and not till you're about 6, that was down there, do you really, 5 or 6 years of age, are you really able to achieve that 20/20 vision that we always talk about? So this is just a normal regular development. You'll see on the bottom here of these little symbols at each different age, you're able to do different and different eye tests. So we'll talk about these, but when you're on 2 or 3, you know some of your shapes, and then 3 or 4 and 5, you start to know some of your letters, but not all of your letters. And then 6, you're getting a little bit better at the alphabet. And that can vary across kids and their skills that they have. So visual acuity testing. So this is what we do for our most youngest children. They don't have to be verbal. They don't have to understand anything, but we do what's called teller preferential looking. As humans, we're able, when we show a card like this, it is our natural tendency to look at this contrast, these black and white stripes. So we have a series of cards that we test kids with that can get a number to that visual acuity. So we can test the youngest of the young to get a quantitative or a number like 2100 or 2080 in these children. And then as they get a little bit older, we'll say, point to what shape you see up there or tell us what. So even the shy kids can point to show you what they see. And then you get a little bit older, and again, you can choose, 1 of 4 letters. You feel a little bit more comfortable, especially if you don't know all of your alphabet, or doctor's visits can be a little bit nerve-wracking as it is. And so this just makes it a little bit more comfortable for them to go through and do this. But then we also contrast that to the extent of your vision or your visual field. So here's a picture of my kids on the beach a couple years ago. And so when we use our visual acuity or our central acuity, we're able to tease out, the words on their t-shirt and the clarity of things. But our visual field is really this stuff, it's everywhere, but it's the stuff kind of in the periphery. The guy back here fishing, the dunes that are there. And again, we don't really think about it that much. But again, it covers all of this area, but this is just a good demonstration of clarity, these finite things versus everything kind of in the background. So when we do vision testing, we do via confrontation. So we can say, cover one eye and I'll hold up, is this a 1 or a 2, or tell me how many fingers I'm holding. For a really young kid, sometimes I'll put a toy in the periphery and see if they look over. Every kid loves a moving toy to kind of saccade or take a glance to. When they're a little bit older, and you have to be a cooperative, probably 8 to 10-year-old that has good focus to do what we call a Humphrey visual field test. It's a computer-based test to tease out how good your visual field is. And something also we call a Goldman visual field, where if your attention isn't as good and you can't really sit in the computer, we have a manual operator work to test your visual field to do that. And we do a lot of that on our younger kids. We've had some kids at 3 or 4 years of age be able to do this pretty well. And so this is kind of what looking inside one of these computers looks like. And there's a little red dot in the middle to focus. And then when the child sees the blue dot pop up in different locations, they press the button as it moves around their visual field. And again, always focusing on the middle to quantitate that visual field. And so this is what some of the printout looks like. And so white is what we see. Here's the left eye, here's the right eye. And the parts that are in black on the periphery here are the parts they didn't see. So they're seeing kind of right in the middle half of their vision and not the lateral half of their vision. And this is how we monitor their visual fields for progression or change. So how do we see, right? This is a concept I think is really important to understand because I think it'll make understanding all the stuff that we talk about a little bit easier. Is our vision system is no different than what you see right here. We have a nice flower sitting in a jar, and a camera takes a picture. The camera sends that information along this cable to the computer and displays it right here. And even the computer could probably identify that that's a flower. So our vision system is no different. Camera, cable, computer. And I think the letters are cut off down below there, but that's okay. We'll show it on the next picture. So here's our camera, cable, computer system. Here's a apple this time. The eye goes in, snaps the picture, it's the camera, sends the vision off along this optic nerve all the way back to the visual cortex in the back of the brain, or we call the occipital cortex, and that is what gives us our vision. That says, that's mom, that's dad, that's an apple. When we magnify up really close to the eye, again, this is the camera here. In the front, you see a thing called, again, it got cut off here at the bottom, this is the lens of the camera. And when you need glasses, this is to help the camera focus, right? So that can be related to anything. It could just be everybody in your family wears glasses. It's not necessarily related to NF, but back when we had cameras like this gentleman had, where you'd actually focus the front, that's really what glasses do for your eye. They help focus that image so the camera or the eye can take the picture. Whereas the optic nerve here is the cable. So it takes all the information from the picture and sends it back. And this is where we focus most of our attention in some of the NF manifestations like optic pathway gliomas. So why we're in the front of the eye, I want to stop and talk about vision a little bit, but the front of the eye here here is the hole in the eye, or that black spot called the pupil. This is where the vision is going in. It's going in this hole. Whereas this iris, or this colored part here, does not let vision through. So on the iris lives these things called Lisch nodules. And you see these little brown, almost stalk or pedunculated like coloration here. And if you are a blue-eyed or a green-eyed person, they tend to be more brownish. They sit on the lower part of the iris here. And if you're brown-eyed or dark iris, they tend to be a little bit more coffee colored for you. Now, they only really help in the diagnosis of NF. There's no other meaning to Lisch nodules in NF. They don't affect the vision, right? The vision goes through that hole, that pupil. So whether you have one Lisch nodule or 1,000 Lisch nodules, it doesn't matter. And it also doesn't relate to, say, if I have 100 Lisch nodules, does that mean I'm going to have other manifestations of NF? And the answer is no, all totally unrelated. You tend to get them starting when you're, anywhere between 2 and 3 years of age, and they kind of reach their maximum around 18. Let's talk about some important eye signs that when you go to see your doctor, they discuss this, or they ask you these questions, and why are they asking, and why does it matter? So ptosis is the drooping of the eyelid. This eyelid up here is nice and high above the pupil. This one is sunken down where it's harder to see the eye. And so why does that matter? It's kind of that same concept as here is that hole or that pupil there where the vision goes in. And if that eyelid covers that, they're not going to get any vision in there. And if you don't get vision in there, and you don't get vision in there properly, you don't also reach that normal visual development scale that I showed you before, which we call amblyopia, or the lack of normal visual development. So that's why that is important. Also, proptosis, or bulging of the eye. So if your doctor sees this in your child and see it sticking out, they worry, gosh, is there something in and around the eye socket or the back pushing forward? Strabismus, or eye misalignment. You can see over here, this child's left eye is kind of pointing in towards their nose, and this eye is more straight. Again, if this eye is misaligned, it's not going to get that normal visual development that I showed you on that scale. So that's why we try to keep the eyes straight. It can be other signs of things going wrong inside the head. If you're concerned your child has strabismus, take a picture. take a picture with the flash on, and you can send it to your eye doctor or your physician, because when the camera flash reflects in the middle of the iris here, but it's way over, or the middle of the pupil and way over here on the left side, we can say, ah, that is real strabismus. We should send you to your eye doctor. Also, eye shaking. Nystagmus is a term where the eyes can shimmer back and forth or up and down. And my buddy here, if you just look here on his left eye, it just shakes back and forth there real quick. It doesn't have to be constant, but it just will bounce back and forth consistently. And again, that's another reason that the doctor may ask you that, or if you see that in your child and your eye appointment's not for another 10 months, it's probably best to go back and see them a little bit sooner. So I put these up here again: ptosis, proptosis, strabismus, nystagmus, all important eye signs to think about for your child, or that the doctor may ask. And then now you have a little bit better understanding of what that is. I'll let you snap a picture of that before I move on. Perfect. So manifestations of NF. So we'll talk about orbital plexiform neurofibromas. These are plexiform neurofibromas just like anywhere else in the body. But for some reason in the face, they like to stick along kind of from the eyelash and up here down to this part of the face. Now, when you look at this child, nothing really pops out to you. On her right side, everything looks good. There's not much ptosis there, but she has a little bit of that eyelid droop compared to that left side. And if you look on the lateral aspect of her left eyelid, it's a little bit more full than the side over here. And so when I touch it and I feel it, it feels soft or boggy or things like that, to say, you know, there's a plexiform in there, and this is something that we should watch for her. So they can be quite subtle. Here's one that's a little bit more obvious, that the plexiform is in and around this child's orbit. It creates a lot of swelling or edema in and around the top and the bottom of the orbit. And then even more severely, where it really stretches out in and along the side and kind of covers the eye there. Who has these? Well, around 5% of the kids with NF1. It may be lower than that. We haven't done great studies to really get down at what the numbers are. We'll have these on the orbital or facial region. They're usually discovered in the first few years of life when we see them. It's rare that it would just pop up and be obvious later in life. The ones that are discovered later in life are really usually those subtle ones that I showed you in that first slide. When you have an orbital plexiform neurofibroma, really depending on the severity of it and how much is going on, your eye doctor may see your child every 3 to 12 months, depending on their age, whether they're out of that visual maturation period or not. And that eyelid drooping, before I said nothing about glasses related to NF is not entirely true. If that eyelid is drooping, it can misshape your eye a little bit to where you may have to update your glasses a little bit more frequently from something called astigmatism. So intervention, and this is complicated, is surgery has been tried to take out the plexiform. Medications have been tried for this. Again, the real reason is to preserve their vision and let their visual maturation go all the way up. Surgery is a little bit complicated in that a lot of times when we remove the plexiform, they tend to grow back. And I've talked to a whole host of children and families, and some people are glad they did the surgery. Others have second thoughts about doing the surgery because of the growth. Now with selumetinib out, I think we have medication options. Some of those children with orbital plexiforms were in that trial. And so again, that is now becoming an option for some children. Again, really kind of depending on what your symptoms are. So what's next? So part of my goal, or what I hope to do, is to get at now that we have medicine to help treat the plexiforms, is are we able to treat the plexiform with selumetinib ahead of time, do the surgery and put the child back on? Is medication alone better than surgery? There's a lot of things the scientists need to figure out to improve the outcomes of these. These are the less common of the plexiforms, and so they're studied less. But in my career, this is one of my goals, to get at this a little bit better so kids have an improved outcome with this. So hopefully more to come. And I also want to give a special shout out to Cure NF with Jack. It's an organization that supports NF research. A number of years ago, probably back in 2012, the family was not satisfied with outcomes and understanding and care of kids with plexiforms. So they gathered a multidisciplinary group of doctors, myself, oculoplastic surgeons, neuro-oncologists, imaging specialists, Brigitte Wiedemann, who you all know if you have a child with a plexiform, and said, get in a room and help figure out the care. And what is the best care? Because doctors are doing lots of different things and there's nothing kind of unified. And so feel free to contact me about this paper or if you see this out there, but they were the ones that really sponsored it, flew all the doctors in for a day and a half. And I'll give you my email at the end if you're interested in this paper, but I think it's a great guide of what is out there. Sphenoid wing dysplasia is not necessarily an eye issue or a primary eye problem, but the sphenoid wing on this MRI helps keep the brain kind of in place in the front of the eye. And in some children with NF1, this bone is not developed fully. And so part of the brain protrudes forward and causes the eye to push out. So you notice the eye finding first, even though it's a bone problem inside of the brain. And so here, again, it's very similar to plexiforms where you're going to do an eye exam and every 3 to 12 months, kind of depending on severity. Sometimes you'll see the child's eye pulse. So if they're laying down in bed and you're looking at them, you might see their eye pulse just with the regular pulse there. And again, surgery really depends on symptoms. If there's lots of complications, sometimes they do put a mesh wire in there to hold the brain back. Again, but it's not very common that we intervene with those. So let's talk about probably the most common eye manifestation is optic pathway gliomas or OPGs. And here, what are these? These are low-grade tumors. These are cancer. We don't call things by malignant or benign anymore. We talk about in their growth pattern. So it was not what we used to call malignant, but they're kind of low, slow-growing, non-explosive tumors. They live along the optic nerve, chiasm, and tracts. Remember that cable system that I showed you? And here's one that lives on the optic nerve. Here are the two eyeballs. And you see this big thickness here. Now, they're inherent to the nerve. They don't sit outside of the nerve. So I can't say to my neurosurgeon, go in and scoop that out, because you would take out the cable. You'd take out the cable and the child would lose vision. And so it's all inherent to that nerve system there. Same thing here where one goes along this optic nerve and goes back into the chiasm where the two optic nerves meet. Sometimes it can just be centered on that optic chiasm there and even go farther back in the brain where we talk about the optic tracts. So who gets these? Well, about 15 to 20% of kids with NF1 will get an optic pathway glioma. But probably half of those, and probably even less than half of those, will these gliomas become problematic as far as vision goes. They'll worry you, they'll worry the patient, they'll worry the doctor, but won't be problematic to where they're going to need treatment. So let's look at it from this perspective. If we take 100 kids from NF1, 80 of them are not going to have a glioma, and you're not going to have to worry about this. Whereas roughly 20%, 15 to 20, will have it. Of those, half, and probably more as our studies are coming out, will not lose vision. And our goal for this group is to really avoid unnecessary treatment. I know that sounds odd, but we want to make sure that if a tumor is not causing a problem, why are we committing your child to chemotherapy, right? That doesn't make sense. And so again, we work hard to avoid this. On the other hand, the other half of the kid, or probably closer to a third, will lose vision from their tumor. And here we're trying to optimize their visual outcomes from the treatment that we're giving them. So this is where we really live of those kids with gliomas, which box do they fall in and how do we do the right thing depending on what box they fall in. So when do we find these? When are these discovered? Usually between about 1 and 8 years of age. There are some kids that are much older for reasons, that they get an MRI or they have headaches or other things that are discovered later, but an overwhelming majority are between 1 and 8. Same thing, for some reason, around 6 to 8 years of age, most of these tumors kind of turn off and they are not problematic after that. Again, NF, I always say, is predictably unpredictable. So there is always an exception to the rule. And so, yes, we've had some kids get treated much later into 10 and 12 and even 15 years of age from their tumor. Why do we how do we monitor them? Eye exams and MRI, usually every 3 months after the first diagnosis when we first discover it. And then some of that can be altered a little bit depending on how concerned we are. And we can stretch it out to every 6 months for a couple years to make sure it's stable. And then it kind of varies a lot from there. But, we look closely and frequently at first to convince ourselves things are stable and then slow down a little bit if they are. Why do we do these examinations? Again, to determine if the glioma is damaging that cable or that vision. So what is involved in the eye exam? I think this is a really important slide, and we're trying to make this standard across all eye doctors and NF doctors out there, is to get that quantitative assessment of their vision, a number to their vision. Asking, when some eye doctors say, oh, follow the birdie or follow the toy, that's good, but that doesn't give you a number. It's very hard to tell when your vision gets worse by following the birdie. And that's why we've been really pushing to get quantitative assessments to this. Visual fields, again, looking at the peripheral and the central, and then visualizing that cable. And here we try to visualize that cable in the back of the eye for its color and things like that. Because why is that important? Well, we talked about this cable system. And so even when the tumor is way back here, if it damages this cable system, that damage will be reflected all the way up here in the back of the optic nerve where we see pallor. So even if the tumor is farther back, we can see problems here. When do we start treatment? And that is an ongoing challenge, but worsening vision from the tumor is certainly a reason to start treatment. And so what is worsening vision? It's tough to kind of discuss in this short lecture, but if you think about our central visual acuity, again, 2 types of vision, that here we're using our finite acuity, but if it goes from something like this to something like this, where it's a lot harder to read those letters and your clarity is worse, that's a reason to start treatment. Same thing here, if they're seeing okay centrally, but you knock out their peripheral vision or their visual field, yet another reason to consider starting treatment. So we look at our approach this way. The tumor's diagnosed, we do a bunch of MRIs and vision tests, you lose vision, and then you move on to treatment. And treatment, again, with most of these occurring under 5 years of age, the peak is around 1 to 2 years of age. Again, there's some outliers here, less frequent, but not unheard of. There's some 5 and 8 and 9-year-olds that initiate treatment for the first time. Again, but most of our kids are younger. And so what are some of those challenges that we also face while we're trying to determine this? This is our eye exam. Kids do not want to do it. They're upset. Your toddler, after seeing their 3rd doctor that day, does not want to have their eyes covered and poked and prodded by the eye doctor and others. And it's hard. And that is typical for all children at this age when it's hard. And so we approach this, we diagnose this, we do the MRI, we find their vision loss and let's move on to treatment. But this is really a terrible approach. We're waiting, the boat has left, right? We've missed the boat. In that if your family members your parents had heart disease and heart attacks and high cholesterol, and your internist said, we're going to wait until you have your first heart attack, and then we're going to go ahead and start treating you for all those things, you'd get up and walk out of the office, right? Because that's not a very proactive approach. And so we have to figure out a way to get better at that and try to get, to avoid or to improve on this process. We also start treatment sometimes if the tumor is large and growing or causing problems. And so, but I want to show you a case that I think is really important to help you understand why this still remains challenging. Here's a young lady I saw when I worked in Washington, D.C. Her parents moved around a lot. Her optic chiasm is normal. And you see right here, this big white bumpy thing is her optic nerve glioma. Her vision was great. Her visual fields are great. Everything about her exam was perfect. We followed her vision frequently. Everything was perfect. The family moved away because they traveled a lot. And then she returned at 5 years and got another MRI. At this MRI, her tumor is demonstrably grown here in the optic chiasm and is much bigger. It was before only in the nerve and now in the nerve and the chiasm. But her exam remained normal. Why would I treat a kid with chemotherapy if nothing's wrong, if nothing's being damaged, if nothing's being injured? And so we deferred chemotherapy and she continued to do well. So back to this challenge here is, yes, when they have vision loss, it's easy and you can start treatment. But if you have tumor growth and move on to treatment, sometimes we do that because that's the best we have and we may not be able to measure vision in an uncooperative kid. But tumor growth does not always mean your child's going to get treated. Also, well, maybe vision loss and tumor growth are related and we get a better handle on it. Those aren't related fully as well. There's some relation, but again, it's not always the case. So it seems like we're in a real mess here, right? We're really having a challenge of, getting a handle on this and what can we do better to improve our outcomes of kids with NF1 OPGs. So some of the work we've been doing in our lab is looking at what's called MRI volumetrics. These tumors are not something you can kind of quickly and easily measure, but we use a lot of computer-based algorithms to extract the whole extent of the tumor, trying to learn more about what about those tumors that grow and don't cause damage versus some of those tumors that grow and do cause damage, or some of those tumors that I'm sure some in this audience have seen stayed exactly the same, yet their child lost vision. So we're working on that to try to get it a little bit ahead of it. Pete DeBlanc at Cincinnati Children's is looking at an advanced imaging technique called diffuser tensor imaging, where we're looking at special MRI techniques to try to figure out which kids are losing vision and which are not. Also, if you go back to the camera and the optic nerve as the cable phenomena, knowing how to look at these optic nerves can be challenging in young kids. And the human eye is only so good, but thankfully we have now machines and technology that will help us do even better than the humans. So if you remember this analogy here, that when the tumor damages things and you see it all the way in the back of the eye, this can be a slow change that is hard for humans to pick up, or in a child that is upset and uncooperative after their third doctor exam. And so there's a device called optical coherence tomography. It's like an ultrasound, and it's super high resolution. So OCT is about 3 micron resolution, just like this little dot down here. It's about half the size of a red blood cell, which is 7 microns. If everybody took out their pen and put a dot on their paper, that's 100 microns. And an MRI is about 1,000 microns. And so this is 200 times more resolute than the MRI that your child gets. So what the computer does is sees the optic nerve here, this little gray and white section here, and it measures around the optic nerve. It gets an idea of how thick those axons and how healthy those axons, and gives us a report. It gives us a report how healthy this nerve is in those different areas. So here's a live view of an OCT as the operator moves in. They're looking at the child, they're putting the measurement over the right place, and they're starting to acquire the image right here. They kind of press the button and it goes. So this whole video is 15 seconds. It gets an ultra high resolution image to say how healthy is your child's optic nerve. But OCT in kids and asking them to hold their chin up there is hard for any child. Again, they don't want to cooperate, normal for a toddler. And so we have a handheld OCT that we can do while kids are asleep. And so when kids get sedation for their MRIs, again, MRIs that their doctor have ordered for their routine care, we kind of piggyback on there. They don't get any extra anesthesia for this. And we just put the dilating eye drops in an hour before they fall asleep. And here is a picture of me when I was in DC. And this child is asleep down here, and we're taking the images live up there of their optic nerve. I press a foot pedal, and within 3 seconds, I get this ultra high resolution image of their optic nerve. I like what I see, and I'm going to move over to her left eye. Just line the camera up over the eye and try to get it into view. Press a foot pedal, and you can see the scanner kind of go right through that. I didn't love that image, so I restarted the picture and tried to refocus it a little bit and get a nice picture there. So this whole video in entirety is 57 seconds. So I got great ultra high resolution images in less than a minute in a child that wasn't cooperative during an awake examination. So what are the goals for these research tools? What can they do for us to change the care? Remember, I was upset of missing the boat and letting the horse out of the barn. So in these cases where the glioma is diagnosed and we do our vision testing and our MRIs, and then vision loss occurs, and then we decide to treat, our goals now are using these tests, OCT, DTI, volumetric MRI, to say, gosh, can we figure out which kids are heading in the wrong direction before they lose a lot of vision, before they can cooperate to do that? Because if we can, could we possibly move our treatment up a little bit earlier than waiting for afterwards and eliminate vision loss all in its entirety? And that's kind of my career goal that I want to see in my lifetime of care for NF kids. So how does my vision change with treatment? If we decided to do chemotherapy, I like to think of the rule of thirds. Is we give chemotherapy, about a third of the kids may get their vision back. Another third, their vision may be stable. And for some reason, about a third of the kids get worse despite our first kind of frontline treatment with chemotherapy. Which is the best treatment for my child? And again, as always, you should always discuss this with your doctor. The most common treatments are carboplatin and vincristine, or even vinblastine. This therapy protocol has been around for 30 some years and hasn't changed. A lot depends on your age and where the tumor is. But again, really, there's a lot of nuances to discuss with your doctor. However, there are some new drugs that have been used recently, and we have published on, and others have published on, that have given us some hope that we might have some more tools. This is a child I took care of in Washington, D.C. He had tried every single chemotherapy on the books. Nothing worked. He was blind. It was down to 30 pounds when he was about 6 or 7 years old. Nothing works. And you know who fixed him? His parents. His parents came to us and said, hey, listen, there's this new drug out here called bevacizumab that's using for adults with gliomas. Could we give it a try? Like, could we just see? And we're like, we've tried everything. We were open to everything. Within treatment, his tumor dramatically shrunk. He regained a good amount of his vision. He regained his weight. He went back to a mainstream school. It was a testament to a family's drive of caring for their child. I'll never forget this young man. Here's a young lady I take care of at CHOP. As you can see, she has significant proptosis here from her tumors. We treated her within 2 months. That proptosis goes significantly down as part of her chemotherapy treatment. So we see some nice effects, and there's some hope there. You've heard a lot about RAS and MAP kinase and selumetinib down here as a MEK inhibitor, and other MEK inhibitors as well. Here is one of the children in the phase 2 trial. We had a significant NF1 OPG, and after treatment, the tumor kind of virtually disappeared on selumetinib. And so this was certainly a lot of hope that we have some new treatments in our armamentarium. Here's a graph of those tumors. So anything below this line means tumor shrinkage or getting smaller. And we certainly see a lot of kids did quite well down here. But a word of caution. Again, I'm very hopeful that selumetinib is a new option for us. I don't know if it's the first line treatment yet. We don't know how sustainable this is. We don't know if we take the kids off, does it come back? Even though the tumor shrunk, is the vision better, right? We are fighting for the vision. We're not treating an MRI scan. We're treating a child. We're treating a child's vision. And my goal is to find the drugs that keeps their vision the best. And so we do have this phase 3 randomized study. I'm a part of it with a number of other people comparing selumetinib to the standard carboplatin vincristine. And again, everyone's very excited and wants to instantly just say, let's not figure this out and go on selumetinib. But as a scientist, this is why we do phase 3 trials, to really figure out, is this better? I hope it's better. I'm crossing my fingers it's better. But is it truly better? Is the quality of the life the same between the two? Is the vision really better? These are things we have to figure out. And so for all the families out there, again, I encourage you to consider participating in the trials if your child falls into this category. I'd also like to give a shout out to Children's Tumor Foundation. For the past 5 years, myself, Michael Fisher, Dr. Listernick sits on the executive board of an international multi-center natural history study of kids that have newly diagnosed NF1 OPGs. So you can't have had it for a year and then get enrolled in the study, but we're following these kids, and we're following these kids to figure out who are the kids that become into that tough category where they lose vision, and who are the kids that do perfectly well, and what are those characteristics of those kids that do better versus worse, again, to help us to try to move into that earlier treatment and prevention of vision loss, instead of waiting for vision loss to occur. And so we have 25 international sites. We have Canada. I keep thinking this is Alaska, but this is Australia down here, and all across the US. And so again, we're very grateful for our families that have participated in this. It's standard of care. We do ask to take certain blood samples if you're interested. We've enrolled well over 200 kids. And in following them prospectively, we're going to follow them really forever. And CTF has made a wonderful investment of us. That's not going to only teach us about optic pathway gliomas. It's going to teach us about all gliomas and other aspects of NF from this data. So I'm very, very thankful. The question always comes up is, does my child need a brain MRI? And it's a good question, and that's a difficult question. 5 minutes. Yep. Is the answer, if your child has no symptoms and your eye exam is good and your child's doing well, no, they do not need a brain MRI. If your child has symptoms, neurologic symptoms or visual symptoms, then yes, you and your doctor will make that decision to have an MRI. But not all children need an MRI. Remember that graph that I had before? 80 of the kids are never going to have a glioma. 90 of the kids are never going to have anything that bothers them. So we don't recommend kids getting a brain MRI. So take home points. Every kid with NF1 needs an eye exam every year, at least until they're age 8. Eye exam should have that quantitative visual acuity. No follow the birdie, fix and follow. Children with NF1 OPGs and plexiforms may need more frequent eye exams, depending on the severity, concern for vision loss, like things like that. Treatment decisions can be challenging, both for the doctor of saying, is this the right time to treat or not? And obviously the family, it's a tough decision as well. And again, we hope these new research tools will get us earlier in the treatment phase and get a better handle on avoiding vision loss in these kids. And I'd like to end with an acknowledgement of the Burke family. This is the Jack right here, who has NF and runs Cure NF with Jack. As a family I met very early in my NF life and career, and great supporters of CTF and others. And he's just a real champion for NF and my hero. Thanks.
Thank you for that tour de force, Doctor. We have a number of questions. Go back to your penultimate slide. I've had this conversation 3 times in the last 48 hours with the parents. Should my child get an MRI? I mean, my center doesn't do MRIs. I know that there are some centers that do MRIs. Why doesn't everybody get one?
It's a great question. I think, everything we do in medicine has to be thoughtful. And I think with our natural history study will hopefully answer some of those questions. And when we have data to say, yes, I'm going to commit your child to anesthesia or sedation, there's risk with that. Sometimes we find other things that are incidental that requires a lot of care. So I don't think we're ready to say every child with NF needs to take on that burden, take on that risk for something that is unlikely there. And I think, again, the eye exams and other things, some of our data is showing is actually really good at picking those things up.
Have you seen a trend of optic gliomas forming after bilateral optic nerve
There, so the question is, if the nerves look tortuous, they kind of go up and down, which is common in NF. Does that mean you are at higher risk for a glioma? Meaning, does it grow into a tumor? I think the answer is no. I see tortuosity all the time in kids with NF1 gliomas. There was one study that says maybe a slightly higher risk of developing a glioma, but not a higher risk of losing vision for the glioma. And that's, again, what we're really looking for is something going on to causing vision loss.
My daughter has an optic glioma. Why do most hospitals have different criteria for the ways they handle vision loss and OPGs?
That is the million-dollar question. I'm sorry to hear that. I've kind of spent my career trying to right that ship. Dr. Listernick's on a couple of papers with us where we're trying to plot that out. I think one benefit of our natural history study that we've done with 25 centers is some centers said, gosh, I don't know if I can really do these teller cards. I don't know if I can really assess the vision this well with kids. And when we put it to them and had them do the study, lo and behold, a lot of people can do it. And a lot of kids can do it. And so this is, and this is almost the benefit of being in a study or a trial. I think you get that upper level of care. So I keep championing for this. And when other doctors from around the world, or we speak about it, this is what I always talk about, the standardized way to do it, because this is what I think the kids deserve. And I think this is the best way to determine whether they're losing vision and whether they need treatment. They're all interesting. They're very great.
Current monitoring guidelines recommend ophthalmology screening every 12 months. However, in the case of a radiologically confirmed OPG, monitoring intervals are every 3 months, and the person references Dr. DeBlanc. Even if asymptomatic, since MRI is not understandably routinely performed, should we not assume the worst and perform ophthalmology screening every 3 months?
That's a very thoughtful question, and thank you for putting the screws to us. We need this. So some of it is a logistical issue of getting children. Again, you're going to get 100 kids in there for the eye tests every 3 months. I don't know if it's sustainable for most places and most institutions. So I don't think it can be done that way. I think when we have an identified OPG that is there, that it's a lot more justified, and that it's not just our time, but it's your time as a family to ask every family here when you have lots of other doctor visit. I think is too much for what I don't think is enough yield. And I say that hesitantly because everything is important here. It's not about yield, but I think it would be overwhelming also to the families.
Okay, my child has an OPG identified in MRI. How is it followed going forward? What are the factors that contribute to how is it followed?
So when we first make that diagnosis, what we usually do is do an MRI at 3 months and at 6 months, coupled with an eye exam. If at that point the tumor's not growing on MRI, then we'll say, all right, then come back every 6 months for an MRI and an eye exam. Now, there are some caveats to that. If your tumor is relatively small, doesn't look like it's too worrisome, then we might ease up on that a little bit more. If it's bigger and kind of in a different, in one of the scarier locations, we may see you more frequently. I didn't talk about it much here, and this is some of the work I've done and done it with Bob, is I think size does matter here, that the relatively smaller tumors are at the lowest risk of causing any damage, and some of the bigger tumors are the ones that tend to cause more damage, especially in the chiasm and the optic tracts. Again, NF is predictably predictable, and I've seen some kids with really small tumors surprise me. But as the general rule of thumb, I think size matters.
Is the OTC test available now for child and adult?
So most every pediatric ophthalmology practice has a regular one in their office. It's very common, especially in all the academic centers and a lot of at larger private practice centers. It is not what I would consider standard of care that every child with NF get one every visit. As much as I do it for research, and I do it a lot, we're trying to do the research to answer those questions. Because also, you know, it would be wrong of me to say, oh yes, every kid should have it, because if you live in a smaller town, you feel like your kid's not getting the best care, and that's not necessarily the case. But what it does is there are certain scenarios where it helps us answer, is this tumor-related vision loss? Is this my kid's not cooperating today? Or are there other things out there? So no, you shouldn't be asking for it, or it's not standard of care. But again, our study is underway, actively underway. Hopefully we'll provide a little bit more data on when it is appropriate to ask for that.
Thank you, Dr. Avery.
And I put the note up here for my email. Just if you put NF1 Summit in the title, I'll get back to you. It may take me a little while, but I'll get there. If there's other questions or you guys wanted a copy of that paper for plexiforms. Thanks.